Hello everyone out there. I welcome you all to the next session of endocrinology, hormone physiology. This is the fourth part of our video lectures. In this fourth part of video lecture series, we shall be discussing about the adrenal gland hormone. Video lectures. In this fourth part of video lecture series, we shall be discussing about the adrenal gland hormone. So let us try to understand what adrenal gland looks like, or what is the anatomy of adrenal gland, what are the parts of adrenal gland. We'll also try to understand that based on these parts, what are the hormones secreted. All right, each part secretes a specific hormone. Each part is controlled by the pituitary gland specifically to secrete a specific hormone, and each part of this gland which is secreting the specific hormone, it acts on various other organs. Each hormone from this small tiny gland, it is acting on various other solid organs like liver, kidney, bones, the uterus, the testis, to secrete and to perform various other functions. So in fact, pituitary is controlling adrenal gland, and adrenal gland is controlling other solid organs. This is what you need to understand. So in this chapter, we shall be discussing specifically how are these hormones secreted, what is synthesized, how are these hormones metabolized, where are they going and acting, what are the functions, and what will happen if there is a deficiency of these hormones. We'll try to understand. So adrenal gland, it is divided into two parts, the cortex and the medulla. It sits on the top of the kidney, so you also call it suprarenal gland. The outermost portion is cortex, the inner central portion is the medulla. The cortex is again divided into zona glomerulosa, zona fasciculata, and zona reticularis. The zona glomerulosa secretes aldosterone. When I was teaching you disorders of kidneys, when I was teaching you hormone physiology of kidneys, I told you how aldosterone is important in controlling the blood pressure. This fact I also discussed when I was discussing cardiology. This aldosterone is actually secreted by the zona glomerulosa, the outermost portion of the cortex, adrenal cortex. This aldosterone is under the control of angiotensin II and also partly by the potassium. Next comes the zona fasciculata. Zona fasciculata secretes cortisol. It is an essential hormone, and along with cortisol, it also secretes androgens. If you remember, androgens are involved in metabolism of fat, in metabolism of various other reproductive hormones, androgen is very, very important. We'll discuss all that subsequently. All right. Now, androgen is also secreted by partly by the liver. Androgens are also secreted by the ovaries. Androgens are also secreted by the placenta in a pregnant female. All these androgens, the source is different, but the action is same. All these androgens, depending on the source, if the source is different, the controlling authority is different. For example, if we are talking about adrenal androgens, androgens secreted by the source is adrenal gland. The source is zona fasciculata of the adrenal gland or zona reticularis of the adrenal gland. This is controlled by the ACTH of the pituitary, adrenocorticotropic hormone. So what are the hormones secreted by zona reticularis? Again, cortisol and androgens. So both fasciculata and reticularis are the same. Both cortisol, both the fasciculata and reticularis, and they are under the control of ACTH. They are under the control of who controls aldosterone? The angiotensin II. Angiotensin II controls, and partly also potassium also controls the zona glomerulosa secreting aldosterone. Hope I am clear. With this, let us discuss what are the important points about deficiency. If suppose there is absence of, if there is an instance wherein absence of zona glomerulosa, what happens? What happens if zona fasciculata or reticularis is damaged or destroyed or deceased, or they are absent or deficiency? So in the absence of zona glomerulosa, aldosterone is absent. If aldosterone, what is the function of aldosterone? To reabsorb water and sodium and to excrete H+ and potassium. So if zona glomerulosa is deficient or absent, aldosterone is gone. If aldosterone is gone, aldosterone is not produced, then sodium is not retained in the body. Patient develops hyponatremia or sodium loss. Patient develops decreased water conservation. So there is decreased volume of ECF. Because there is decreased volume of ECF and reduced volume of sodium, obviously there is low blood pressure. So patient undergoes circulatory shock and person dies. So death eventually occurs because of lack of low blood pressure, no cardiac output, no blood reaching the brain death occurs, and suddenly patient dies. So this is what happens if zona glomerulosa is absent. If zona fasciculata and zona reticularis are absent, so the glucocorticoids, cortisol is glucocorticoids, cortisol and the androgens are absent. And this results in the cortisol. If cortisol is absent, then cortisol, what is the important effect of cortisol is it stimulates the catecholamines. So epinephrine, norepinephrine. Cortisol is stress hormone. It stimulates, it causes fight, flight or fright based on its control of sympathetic system. So what will happen? This control of sympathetic system is gone. Catecholamines are not produced. There is no vasoconstriction. Because of this, patient develops shock. Another important point is cortisol or steroids, that is the glucocorticoid, also helps in mobilizing the glucose, mobilizing the fats from the stored form. So our body tries to store glucose in the form of glycogen and fats. So this, whenever there is a stress, for example, you are fasting, for example, you are exercising and you are not taken your food properly, glucose is not present, but brain works only with glucose. So our body tries to cut this glycogen during exercise, during fasting, cuts glycogen and provides glucose to and whole of the body, including brain, muscles, bone, which are important to work. Hence energy, ATP is formed. Hence we are able to perform activities. But what will happen is, if we are assuming that the fasciculata is absent or deficient or disease, the reticularis is absent, so no cortisol. If there is no cortisol, there is no mobilization of glucose, no mobilization of fats. That results in sudden deficiency of energy. If ATP is not available, that is very, very life-threatening disorder. All right, patient develops severe hypoglycemia. One of the important causes of hypoglycemia is absence of cortisol, glucocorticoids. All right, remember this fact. And if say suppose, now this we are talking about adrenal gland disorders, is it not? That is loss of zona glomerulosa or reticularis. All right, the say suppose who is controlling the zona glomerulosa? It is the ACTH, that is the zona fasciculata and reticularis. Who is controlling it? Is the pituitary. If suppose there is a problem with the pituitary gland, then the steroid synthesis is affected. Steroid synthesis is the only thing that is affected, whereas zona glomerulosa is normal. If there is any disease of the pituitary, because ACTH is controlling the release of steroids, adrenocorticotropic hormone, ACTH stands for, that is controlling the zona fasciculata and reticularis, and that results in disease of if aldosterone is normal, mineralocorticoids remain intact, right? Let us try to understand the biosynthetic pathway of the steroids. To understand this, we need to first quickly revise what are the hormones secreted. I didn't tell you what are the hormones secreted by the medulla, the centermost portion. The medulla secretes epinephrine. All right, epinephrine. So let us try to understand what are the adrenal gland hormones. There are two types of hormones. I am revising it: mineralocorticoids and catecholamines. Mineralocorticoids is the first part. Second type is glucocorticoids. Third type is androgens. And fourth type is catecholamines. Fifth type is peptides. Please remember that the mineralocorticoids, glucocorticoids, the androgens, and the peptides, these are secreted by the cortex, adrenal cortex, the outermost portion. Medulla secretes the catecholamines. So medulla secretes, if you follow this arrow, catecholamines secreted by the medulla, that is epinephrine, norepinephrine. What are the categories of mineralocorticoids? It is aldosterone and the corticosterone. All right. What are the examples of glucocorticoids? Cortisol and cortisone. What are the examples of androgens? Estrogen, testosterone. What are the examples of peptides? Somatostatin, substance P. All right. So these are the three parts: the zona glomerulosa, zona fasciculata, and zona reticularis. This is the kidney, on the top of which the adrenal gland sits, and you are calling it a suprarenal gland. You call it a suprarenal gland. All right. You call it suprarenal gland. So the aldosterone, the cortisol, epinephrine, and androgens, these are the four types of hormones. Let us repeat our same thing again. These are the four types of hormones. These are the four types of hormones secreted by the adrenal medulla. Aldosterone is acting on kidneys, and what is the function of aldosterone? To conserve sodium and water. Sodium, water absorption into the body, and excretion of H plus and excretion of potassium. This is an important function of aldosterone. Cortisol acts on liver. Cortisol acts on liver to convert glycogen to glucose. Can I call it glycogenolysis? Yes. So it helps in glycogenolysis. Epinephrine acts on liver to produce glucose. Epinephrine acts on the heart. Beta 1 and beta 2 receptors. Beta 1 receptors present on the heart. Beta 2 receptors present on the blood vessels. Epinephrine acts on the muscles and exerts its effects. Androgens act on the male sex organs and the female sex organs, and they bring about changes in the male and female sex organs to produce testosterone and estrogen respectively. All right, let us try to understand how are these, what the synthesis of steroids. All right, so on the right side of your screen you have got zona glomerulosa, zona fasciculata and zona reticularis. The important hormone that is secreted in the zona glomerulosa is aldosterone. It's an important hormone that is secreted by the zona glomerulosa. So this is how it is synthesized. If you follow on the left side of your screen, that is the cortisol, that is the cholesterol. Cholesterol gets converted to pregnenolone. Pregnenolone is acted upon by this enzyme 3-beta hydroxysteroid dehydrogenase, 3-beta HSD. It's not important now, but in biochemistry I'll definitely discuss this enzymes which are bringing about these changes. In medicine also I'll discuss this point, but right now try to understand that it's a very important enzyme that converts pregnenolone to progesterone. From here, progesterone is getting converted to deoxycorticosterone. Deoxycorticosterone gets converted to corticosterone. Corticosterone gets converted to 18-hydroxycorticosterone. From here, aldosterone is formed. What is the function of aldosterone? We all know that aldosterone helps in sodium and water reabsorption and potassium and H+ excretion. Next, pregnenolone, next step, gets converted to I'll change the color of my to green. So pregnenolone gets converted to 17-hydroxypregnenolone. From here it gets converted to progesterone and deoxycortisol to cortisol. Pregnenolone, if it gets converted vertically down into DHEA, that is dihydroepiandrosterone acetate. DHEA is a potent androgen, please remember. From here, because of action of 17-hydroxylase, this enzyme, and 1720 lyase, this enzyme, androgens are formed. Because of the action of 3-beta hydroxysteroid dehydrogenase, 3-beta HSD, the reaction is occurring on the horizontal plane, resulting in formation of aldosterone and cortisol respectively. If it is occurring in the vertical side, that is the 17-hydroxylase, 1720 lyase, these two enzymes are responsible for production of androgens. And these androgens are DHEA androgen, which gets converted to androstenedione, present on your screen, and with various other reactions, like it's a potent androgen, androstenedione, and dihydroxyepiandrosterone acid, that is DHEA. DHEA and androstenedione, these are also called as 19-carbon moieties, C19 or 19-carbon moieties. C19 we call it, C19. 19-carbon moiety, these are the adrenal androgens, very, very strong adrenal androgens. And these adrenal androgens are responsible for formation of testosterone, the estradiol, the estrone, the adrenostenediol, that is all the sex hormones. All right. So the hydroxysteroid dehydrogenase enzyme and the 17-alpha hydroxylase enzyme, these enzymes are important in metabolism of cholesterol. Cholesterol is the main precursor, and cholesterol is obtained from LDL. All right. So LDL is offering cholesterol getting converted to pregnenolone. Pregnenolone has two pathways, either to go in the form of progesterone and form aldosterone, or get acted upon by 17 alpha hydroxylase to form 17 hydroxyl steroids, that is the cortisol, or by 1720 lyases to form androgens, that is the 19 carbon moiety. All right. On the androgens, again various enzymes act and it results in formation of testosterone, estrogen and estradiol, that is on your screen, right? I think to look at this slide once, it's highly confusing, but don't worry, I'll again revise this topic in biochemistry. All right, here it's not that important. I'm just discussing because basics of hormones we need to understand. But in biochemistry, cholesterol synthesis and metabolism, again I'll discuss this, and we'll discuss certain diseases which are important here. All right, I'll come back to this slide shortly. So please remember that the carbon 19 atoms or carbon 19 steroids are the androgens. I told you adrenal androgens are called as carbon 19 steroids. The adrenal androgens, that is the dihydroepiandrosterone acetate, the androstenedione, these are important androgens. Out of these, the major androgen is DHEA. All right. In males, obviously, they are responsible for prepubertal changes. They are responsible for enlargement of the penis. They are responsible for early development of secondary sexual characters in males. In females, by default, these are responsible for production of estrogens, and estrogen again further responsible for androgens and estrogens for secondary sexual characters, for the menarche, that is beginning of menstrual cycle, etc. How is this important clinically for us? Please remember that if person presents to you with secondary sexual disorders, secondary sexual character disorders, or delayed puberty, or sometimes precocious puberty, that is puberty occurring at a very small age, or puberty not occurring at all, no changes during puberty, so at that time you can draw a conclusion that there is some problem with the adrenal androgens. All right, and then you can start your treatment. Please remember that urinary excretion of these androgens is important clinically. Urinary excretion of these androgens, that is the 17 ketosteroids, that is the carbon 19, that is and the androgens, the testicular hormones, and in females the estrogen and all these are excreted by the urine, and you can also detect the levels in the body. All right, there is one important enzyme called as aromatase. This aromatase enzyme converts androgens to estrogen. Androgens to estrogen. This enzyme is so important that, give me a second, please. I'm very sorry, I was muted for so long. I'll repeat from here. I'm sorry, I was muted for so long. I didn't see whether, I mean, I'm really sorry. So I repeat from this part. I was saying that androgenism, hyperandrogenism is an important disorder. Now, aromatase enzyme converts androgen to estrogen. Aromatase enzyme converts androgen to estrogen. How to detect androgen levels, whether the person is suffering from hyperandrogenism or not? You should check the serum DHEA levels. Serum DHEA levels you should order to the patient. Check in the blood levels of DHEA, and if it is high, you call it hyperandrogenism. What are the clinical features of hyperandrogenism? Hirsutism in females, that is abnormal excessive hair. Then acne, because on the face a lot of sebum secretion and oily secretion occurs because of hyperandrogenism, that results in harbor of bacteria resulting in acne vulgaris, that is a lot of acne on the face. Then hyperandrogenism causes increase in adipocytes and secondary to lipolysis lipid disorders. It results in obesity. Increase in adipocytes in turn cause insulin resistance. That is the next point, insulin resistance. Because of insulin resistance, long-standing insulin resistance, patient develops diabetes type 2. On the skin of axilla and neck, patient develops thick black pigmentation, you call it. All right. So because of insulin resistance, thick black pigmentation on the neck, on the axilla, on the groin, you call it acanthosis nigricans. Acanthosis nigricans. So these are all the important points about hyperandrogenism. Our aim was to discuss the synthesis and secretion of various steroid hormones. Let us try to understand the physiological functions of these hormones. All right, I'll come back to this this flow chart. This flow chart is very, very important. Actually, 2 or 3 times if you revise, you will able to understand what are the important hormones secreted. I'll come back to this this slide again in my subsequent class. But right now, let us discuss the important physiological actions of glucocorticoids. I already told you a few important physiological actions of glucocorticoid, that it is a stress hormone that is important during stress. It is a stress, one of the stress hormones. It mobilizes glucose from, or mobilizes the energy. You can call it mobilizes energy stores, that is glucose and free fatty acids from glycogen. All right. It acts on the growth hormone to mobilize fatty acids by causing lipolysis from the adipose tissue. This action is via the growth hormone. Remember this point. All right. There is one important hormone called as glucagon. Glucagon is secreted actually by the pancreas. So the stress hormones, the important stress hormones are glucagon, the growth hormone, the cortisol, and the epinephrine. So these are all the examples of stress hormones. These are all the examples of stress hormones. The glucagon, growth hormone, cortisol, and the epinephrine. The glucagon, it mobilizes glucose by increasing the glycogenolysis. Increases glycogenolysis. glycogenolysis, that is movement of that is breakdown of glycogen to glucose. Growth hormone acts on the adipocytes. Growth hormone acts on the adipocytes to release free fatty acids. These free fatty acids are also rich source of energy. When glucose is absent or sometimes in stress, especially during myocardial infarction, heart tries to bring out its energy reserves from the free fatty acid metabolism. All right. So thanks to the growth hormone which is helping it during stress. All right. Then cortisol mobilizes fat, mobilizes proteins, mobilizes the glucose, that is carbohydrate, by various mechanisms we'll discuss in detail. Epinephrine, how does epinephrine help in stress? It mobilizes again glucose via the glycogenolysis and fat via the lipolysis. So it is acting on both glucose metabolism, glycogenolysis and lipolysis. All right. So if you see the final common pathway, if you see all these stress hormones, what is the final common pathway? All these stress hormones are increasing glucose. Stress hormones are actually increasing the glucose, plasma glucose, and especially in case of hypoglycemia, the stress hormones are very, very important in improving the glucose, rapid increase in the glucose. And because these hormones, they raise plasma glucose, they are referred to as counter regulatory hormones. All the stress hormones, that is the growth hormone, the glucagon, the epinephrine, and the cortisol, these are termed as counter regulatory hormones. They are countering whom? They are countering the boss, insulin. Insulin is the boss. When I discuss pancreas, I'll again tell you why insulin is the boss. Because it is metabolizing the glucose. It's helping in glucose uptake. All right. So they are countering the boss, that is insulin. They are acting up against insulin, especially during hypoglycemia, to increase the glucose. All right. And in other words, if I turn the topic around and I tell you that there is stress, there is deficiency of growth hormone, what will happen? Deficiency of glucagon, what will happen? Deficiency of epinephrine, what will happen? Deficiency of steroids, cortisol, what will happen? Then your answer should be hypoglycemia will occur, because all these hormones, if they are lost, there is no increase in glucose, and conversely hypoglycemia occurs, or there is no counter regulatory mechanism to insulin action, and hypoglycemia occurs. What are the important effects of cortisol? Let us try to understand. Cortisol is promoting the mobilization of protein by hepatic gluconeogenesis. Hepatic gluconeogenesis. By hepatic gluconeogenesis. Please remember that the cortisol, it promotes the free fatty acid mobilization by lipolysis. By lipolysis, that is, free fatty acids and glycerol are delivered. Cortisol acts on the increase in blood glucose directly by making more glucose available for the brain. That is more important. Cortisol is responsible for glucose delivery to the brain. Cortisol, because it is counteracting the insulin, it is having dual benefit. It is not only counteracting the insulin, it increases glucose directly and supplies to the brain by two mechanisms. One is by increasing the glycogenolysis. The glycogenolysis. And secondarily, by counter regulation of insulin. That is, the steroid counter regulates the insulin where? In the muscle, in the fat, especially in the muscle, in the fat. Lymphoid tissue. All right, all these are important examples. The cortisol increases the hepatic output of glucose by two mechanisms. One is glycogenolysis, another is gluconeogenesis. I told you. How does it do it? By regulating the enzymes of gluconeogenesis, by regulating the enzymes of glycogenolysis. All right, all these hepatic output of glucose is increased. All right, now cortisol, apart from directly causing all this, it also promotes the action of glucagon. It also promotes the action of epinephrine, other stress hormones. It also promotes the action of glucagon and epinephrine, the catecholamine, the other stress hormone, and thus it helps in, you know, increased delivery of glucose to the nervous tissues and also the other various part of the body. How is this cortisol controlled? The cortisol is controlled by the pituitary gland. The cortisol is controlled by the pituitary gland. All right. So just one second. So we have already discussed this in our last class. The cortisol releasing hormone from the hypothalamus. It acts on the anterior pituitary to release ACTH, pituitary gland. From here, this is acting on the adrenal cortex. Where in the adrenal cortex? Zona fasciculata and reticularis. Zona fasciculata and reticularis to secrete cortisol. And cortisol has got various functions. All right. Cortisol has got various functions. Now this cortisol, it causes negative feedback mechanism. It's an important point. On hypothalamus, it causes negative feedback mechanism on the pituitary. Negative feedback mechanism on the hypothalamus, negative feedback mechanism on the pituitary. The ACTH, it has got two important roles. One is to act on the adrenal cortex to produce cortisol. It acts on the lipotrophins. It tends to produce lipotrophin, which in turn produces melanocyte stimulating hormone. This melanocyte stimulating hormone is responsible for the various important functions like pigmentation of the skin of the scrotum or pigmentation of the skin of the groin. It also helps in understanding with the help of suprachiasmatic nucleus. Suprachiasmatic nucleus. It also helps in sleep wakefulness cycle, sleep cycle. All right, all these factors, all these points I'll discuss again when I'll be discussing the sleep pathway separately in physiology, right? So these are all the important effects of cortisol. This is how cortisol is regulated and this is how cortisol acts. Let us try to understand the physiological actions of aldosterone. I already discussed physiological action of aldosterone, but still I'll jot down the points for your better understanding. So important effects is sodium absorption, sodium reabsorption you can call it. The water reabsorption. What will happen if sodium reabsorption and water reabsorption occurs? The ECF volume increases. So this increases the ECF volume. this raises the blood pressure. This increases the blood pressure. So this is an important effect of aldosterone. Another important effect of aldosterone is excretion of H plus, excretion of potassium. So this results in excessive excretion will result in hypokalemia and metabolic alkalosis. This is excess. I'm talking about the disease. Alright, I'm talking about the disease. Excess of hyperaldosteronism, that is primary hyperaldosteronism, can cause very resistant hypertension in young people. Very, very rare cause, but still primary hyperaldosteronism. Alright. Aldosterone, it stimulates the H plus secretions. When I was discussing H plus secretion, that is acid base disorders, if you remember, I was talking about a cell called as intercalated cells. Intercalated cells. So it is the intercalated cells through which the aldosterone is acting. This point, if you go back and see my chapters of acid base disorder, my first chapter, I told you this point, intercalated cells. So intercalated cells are acted upon by the aldosterone to excrete or to secrete H plus ions. Thus aldosterone promotes alkalosis, please remember. And aldosterone, if it is deficient, it causes acidosis. Alright. Excess will produce alkalosis, deficiency will produce acidosis. Deficiency of aldosterone will result in which type of acidosis? Renal tubular acidosis type 4. In my class of nephrology, I told you nephrology basics about renal tubular acidosis type 1, type 2 and type 4. So type 4 renal tubular acidosis is nothing but because of hypoaldosteronism, right? Aldosterone is controlled by two factors. Aldosterone is controlled by angiotensin II and indirectly by the potassium levels. To understand this, you need to understand I already discussed this point also in my nephrology class, but still I want to highlight it, and it is the regulation of aldosterone by this slide. So in this slide, if you can see, this is the, if you are able to follow, I am highlighting the angiotensin II. Angiotensin II has got a stimulatory action on aldosterone. Angiotensin II has got a stimulatory action on aldosterone. Angiotensin II has got a stimulatory action on aldosterone. This aldosterone is acting on the renal tubule to increase potassium excretion, decrease serum potassium. It increases the sodium and water reabsorption, causing increase in the blood pressure. This point you already know. Angiotensin II directly acts on the kidneys, proximal tubules of the kidneys to cause this. Angiotensin II directly acts on the ADH, it increases the ADH release via the pituitary gland. Angiotensin II receptors, type 81 receptors, they cause directly arteriolar vasoconstriction. This also raises the blood pressure. So there are three mechanisms by which angiotensin II is acting. Angiotensin II is acting. One is the renal mechanism, another is the central mechanism. The third one is the vasoconstrictor mechanism. Vasoconstrictor mechanism directly on the arteriolar constriction. This is the third mechanism. Second mechanism, I told you, central mechanism acting on the pituitary gland to release lot of ADH and thirst, causing increase in the ECF volume. Angiotensin II affects the kidneys, both proximal tubule and distal tubule. Distal tubule via the aldosterone, proximal tubule directly. This is an important point. I repeat, the action of angiotensin II on the kidneys. The action of angiotensin II on the kidneys is dual, proximally directly, proximal convoluted tubule directly, and distal convoluted tubule via the aldosterone. Aldosterone is secreted by the zona glomerulosa of the adrenal gland. Alright. If you remember, where is this angiotensin II coming from? Angiotensin II is coming from ACE, that is angiotensin converting enzyme. The angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Renin converts angiotensinogen to angiotensin 1. This is important. Renin converts angiotensin. Renin is a hormone which converts angiotensinogen to angiotensin 1. Then ACE, that is the angiotensin converting enzyme, converts angiotensin 1 to angiotensin 2. Pharmacology, will discuss slightly important pharmacology here so that we get some interest in understanding this. We can block ACE enzyme by ACE inhibitors. Examples are enalapril, ramipril. We can directly block the angiotensin 2. The final common pathway is angiotensin 2 by angiotensin receptor blockers like telmisartan, azilsartan, irbesartan, I'm sorry. So these are all the examples, angiotensin receptor blockers. You can directly block renin, hyperreninemia, in conditions of hyperreninemia causing aldosteronism, or causing high BP, hyperreninemia. You can block it by using aliskiren. This is an important drug which is called as renin inhibitor. Alright, or simply you can block the aldosterone by aldosterone receptor antagonist. What are the important aldosterone receptor antagonists? Spironolactone, eplerenone, milrinone. These are the important aldosterone receptor blockers which block the aldosterone and thus reduce the blood pressure. These are the drugs, antihypertensives, that we are talking about. So to conclude the chapter today, I'll quickly discuss an important effect. To conclude the chapter today, I'll discuss the synthesis of hormones from zona glomerulosa, zona fasciculata and zona reticularis. Zona glomerulosa secretes the aldosterone, that is the mineralocorticoids. Zona fasciculata and reticularis secrete the cortisol, the androgens, the testosterone. Alright, and then androgen getting converted to estrogen by the enzyme aromatase. This all I have already discussed. Alright, please remember, cholesterol is the main culprit. I'm sorry, I should not call it culprit. In diseases it is culprit, but normally physiologically it is an important precursor of all these hormones. That's why cholesterol is very, very important for you in your diet. We think that cholesterol is not important and we try to avoid it, but it is important in certain extent. It is important, right? Cholesterol gets converted to pregnenolone. Pregnenolone gets converted to progesterone. Progesterone gets converted to 11-hydroxycorticosterone and then finally to the aldosterone. 11-hydroxycorticosterone is a potent mineralocorticoid, please remember. Alright. Excess causes alkalosis, deficiency causes acidosis. Simple. Then pregnenolone, by action of 17-alpha hydroxylase enzyme. 17-alpha hydroxylase enzyme, it results in formation of 17-hydroxyprogesterone. 17-hydroxyprogesterone. Now here one enzyme I would like to introduce. This enzyme is 21-alpha hydroxylase enzyme. This enzyme, 21-alpha hydroxylase enzyme, is responsible for conversion of progesterone to cortisol. Imagine a condition wherein this enzyme is absent, deficiency of 21 beta hydroxylase. If this enzyme is absent, what will happen? If this enzyme is absent, there is blockade of, the formation of 11-deoxycortisol will not form, cortisol will not form. So patient will develop what? Deficiency. Patient will develop deficiency of cortisol. So there is alright. This 21-alpha hydroxylase is also responsible for conversion of progesterone to 11-deoxycorticosterone. So there is deficiency of aldosterone. There is a deficiency of aldosterone. There is deficiency of cortisol. Patient develops mineralocorticoid deficiency. So that results in deficiency of aldosterone related disorders, right? Like BP is very low, patient develops circulatory shock and acidosis, and patient may die sometimes. All right, congenital deficient hydroxylase. So remember, there are two blockade points here. Blockade point number 1 and blockade point number 2. These are the two important blockade points resulting in deficiency of mineralocorticoids and cortisol. All right. So the zona glomerulosa deficiency results in decreased aldosterone. Zona fasciculata reticularis deficiency of 21 alpha hydroxylase results in that is decreased production of 11-deoxycortisol deficiency. Because of this, patient develops loss of sodium and water resulting in salt wasting, mineralocorticoid deficiency. There is increased renin secretion, and because of this, what happens is there is and also separately the decreased corticosterone production. All right, the glucocorticoid deficiency with an increased ACTH. Please remember here, because the problem is in adrenal gland, what pituitary thinks is, let us produce more ACTH, let us stimulate the cortex more. So this is how we differentiate the central disorder from the peripheral disorder. If there is a disorder of the pituitary, obviously ACTH will be low. If there is a disorder of adrenal gland itself, by absence of these enzymes, ACTH levels are very, very high. So please remember that the deoxycorticosterone, if it gets accumulated, so this deoxycorticosterone is an important potent mineralocorticoid. If this accumulated in the blood, the patient develops high blood pressure. All right. So this is all about deficiencies of these enzymes. This pathway again I'll discuss when I'll be discussing the cholesterol metabolism in biochemistry. Right. So to summarize, if a patient develops 21 beta hydroxylase deficiency of this enzyme, so what will happen to the glucocorticoids? Let us see. What will happen to the ACTH? What will happen to the blood pressure? What will happen to the aldosterone? What will happen to deoxycorticosterone, which is a potent mineralocorticoid, precursor of aldosterone? What will happen to the androgens and what will happen to the estrogens? Let us try to understand, summarize. If there is a 11 beta hydroxylase deficiency, what will happen to all these? 11 beta hydroxylase deficiency reduces the glucocorticoids, but the feedback mechanism is increased. Hence, pituitary starts secreting more ACTH. All right. What will happen to the blood pressure? Blood pressure is low. Blood pressure is low because aldosterone is absent, deoxycorticosterone is absent, and there is no deficiency of androgens or estrogens. Androgen and estrogen, there is no deficiency. In fact, excess raw material is available to make synthesize androgens more. So hyperandrogenism with the low blood pressure, with hypoaldosteronism, hypocortisolism is an important effect of 21 beta hydroxylase deficiency. What will happen if patient develops 17 alpha hydroxylase deficiency? 17 alpha hydroxylase deficiency, it actually decreases glucocorticoids, it reduces the aldosterone, but an important point here is there is an increase in deoxycorticosterone, which is a potent mineralocorticoid. If there is increase in deoxycorticosterone, there is increase in blood pressure, and obviously because cortisol is less, there is ACTH is increased. So high BP with increased ACTH, your diagnosis is 17 alpha hydroxylase. Low BP, that is hypotension with increased ACTH, your diagnosis is 21 beta hydroxylase deficiency. The 21 beta hydroxylase deficiency, also termed as congenital adrenal hyperplasia. Congenital adrenal hyperplasia. The congenital adrenal hyperplasia, in other words, it is 21 beta hydroxylase deficiency. 21 beta hydroxylase deficiency. And there is mineralocorticoid deficiency, there is salt wasting, there is I already told you that BP is low. All these important points are there. We'll discuss this again in endocrinology. In 17 alpha hydroxylase deficiency, this is how to differentiate and all, I already told you. All right, we'll conclude this chapter here only. Then in our next chapter we'll discuss adrenal medulla. Till then, have a nice day, and repeat this video again and again so that you understand. If you have any doubts, please come back to me. The email ID is displayed. I'll definitely help you out with your doubts, right? Thank you so much.